All right. Well, thank you so much for having me. I'm excited to be here with you guys tonight, and I'm glad that you reached out to me and saw the presentation on NDA, or at least somebody told you about it. So it must have been all right. You're excited to be here. Um, so thank you, Dr. Jackson, for reaching out. You know, a little background about me. I know that it was in the bio, but I am a dental hygienist, and I started developing tips and medical billing. I'd been to many presentations on medical billing and couldn't understand why it wasn't successful. In that, I did a lot of digging and realized that what was missing was in the whole link of this was the implementation part of medical billing. So I created tips, or tandem in practice solutions for medical dental billing. And here's my mission statement. What I also was finding in the industry too, there was a lot of companies coming to the forefront with this, but I was seeing a lot of fraudulent things. And as a hygienist, I hold my license very close to my heart, and I wouldn't want anybody to take it away from me. So it gave me even more passion and drive to want to create something more for our industry. And in, the core values of TIPS is integrity, ethical beliefs, and transparency, because dealing with some of the other companies that I've seen out there, that wasn't always the case. So again, I hold our profession very high, and I want it to excel, and I want it to be the best that it can be. And we're seeing so much more movement towards medical billing, and it's super exciting. I think right now, I know COVID has been a real tough time for many practitioners and many practices, but I think, we are at a really cool stage of dentistry. And I just couldn't be more excited about where our profession is at and the direction it's going. And medical billing is absolutely one of those things that are being incorporated into dental practices to elevate them. So my goal for tonight is to really show you the opportunities that exist in medical billing. There are so many, and so many that people just don't realize unless you're actually doing it and you have somebody coaching you through it. And you might hear stories, and you might hear stories of success or failure, whatever it is. I want you to know that there's a ton of opportunities, and those opportunities are only going to get stronger and stronger and stronger. So it's an exciting time for dentistry. I think one of the biggest things that we have to start doing is shifting our mind about what we are. We're not just a hygienist. We're not just a dentist. We are so much more. We undervalue ourselves. And there's no doubt in my mind that we undervalue ourselves. And I hear it all the time. I'm not even sure why dentists are called dentists, or why hygienists are called hygienists. To me, a dentist talks only about the teeth. That's what it means teeth. Hygienist, to me, that's like cleaning. It's not, that we're so much more than tooth cleaners. We're so much more than dentists restoring teeth anymore. And we have to start valuing what we bring to the table and what we offer to the public as a whole. And we need to embrace that. And we need to elevate ourselves, because we are absolutely a medical provider. So we need to start looking at ourselves that way. One of the biggest mind shifts that we need to make is that dental insurance is a supplemental insurance. It should be looked at as a supplemental insurance, not a true policy, insurance policy at all. It is a supplemental insurance, and it has benefits with a lot of limitations, restrictions, and exclusions to it. We all know that, it was back in the 1960s when our limits were set on dental benefits, and those numbers haven't raised since then. So our limitation is the patients only have a small chunk of change that they get to spend per year. I still remember when I first got out of hygiene school, we had patients on a 5-year plan for restorations. That was back in 93. So things have changed a bit, but knowing what we know about the oral systemic connection, that's insanity to think that we should have somebody on a 5-year plan while that disease continues to fester in their mouth. So growing up in Minnesota, I love this from the Mayo brothers. They were very instrumental in medicine and as well as in dentistry. Way back in 1910, they were already talking about how the mouth was a gateway to good overall health. It makes sense. It just simply makes sense. How can we disconnect the mouth from the rest of their body when that's where everything enters? How can we disconnect periodontal disease that it doesn't affect the overall health of the patient? It absolutely does. So we need to start shifting our mind as to oral systemic connection, which has gotten stronger and stronger over the years. I love it. I love that part of this whole process, because at the end of the day, that's what it's really all about. We're trying to make people healthier. We just have to look at a different way of how to tap into them getting benefits for their care. If we look at oral systemic and even microorganisms within 1 minute, if the blood's coming out, the bacteria is going in, and within 1 minute, that bacteria has now entered all the arteries, all the organs, the capillaries. It's that bacteria is swimming through the entire body. So again, we have to look at dentistry different. It's not just about the teeth anymore. We also know that within about 30 days that a patient can have a vascular event from an oral procedure, which is mind-boggling to me as well. But we know that to be true, and we're seeing that especially with patients that have periodontal disease and that have cystic lesions or abscess teeth. Those patients are 50 times more likely to have a heart attack or stroke. So, we have to start looking at ourselves as a true medical professional, true medical specialist, I guess you could say. We're not just examining the teeth anymore. We're doing a full head and neck evaluation. And in academia, you know that. I mean, we're doing a full head and neck TMJ evaluation. It's not just about counting teeth anymore. So how do we get reimbursed for that? Because on average, I would see probably dentists getting reimbursed for an annual eval about $30. That doesn't cover our costs. It can't, and especially now with PPE being so needed, and all of that has come forward with the COVID crisis. So I get asked this a lot: can we really bill to medical? Yes, we can, and we can be paid exactly the same as any other specialty. And this is the statute that I use quite frequently when we start billing to medical for a new dental practice. We start to get rejection saying, I think you meant to bill to dental. No, we didn't. We meant to bill to medical. So I often send this along with a nice little letter saying you need to pay us because you're breaking statute. You're breaking the Affordable Care Act, and that's not cool. So pay us, and we get paid. So this does work. And it's no different. If an ENT can bill for an evaluation, so can we. They can't discriminate against our provider type. So that's pretty cool. We can actually bill to both dental and medical. They're two separate policies. They're not two medical policies. One is totally a dental benefit policy. It'd be no different than your auto insurance, or no different than Aflac or Colonial Life policies that you're paying a benefit, you're paying in premiums for this benefit. Now you need to tap into it. So you can bill to both dental and medical. You can't keep a penny more than you charge the patient, but you can tap into both. So what is it that you can actually bill for? Evaluations. You do thousands of those in a year in a practice, thousands, and all of them can go to medical. Radiology. So your CTs, lateral ceph, PANS, PAs, and things like that can often be billed. PAs typically are not billed unless it's trauma. But anything that, a CT is showing more than just a tooth. It's showing bone and all the structure around it. For surgeries, so implants, grafts, stents, interim and final prosthesis, anything that goes along with that surgery is billable to medical. Biopsies, TMJ treatment, Botox for jaw pain. I was just working on 3 prior authorizations today on Botox, and that provider is getting paid nicely for her Botox treatment. Sleep apnea, and also all the diagnostics for all these things too. A patient has to come in and be evaluated, right? Now we treat. So it all goes hand in hand. Trauma. Trauma usually trumps everything. I do see policies that exclude oral trauma for benefit, but most of the time not. Frenectomies, advanced oral cancer screening like Velscope or Oral ID. Fluoride varnishes are covered by medical. Dental restorations can be covered by medical as well. If you are, in particular, somebody that's had cancer or somebody that has had or has a medical systemic condition that's creating the problem in the oral cavity. So there are a lot of things that can be billed to medical. The biggest thing that we need to understand, and this is something that's very different from dental, we have to establish medical necessity. Now, if you've ever been audited by a dental carrier and not established medical necessity, you're probably going to pay money back. So establishing medical necessity on a dental claim form, you don't have to do that. You can submit procedures all day long without having a reason for doing them. But that's why often they ask a lot of questions. Send us the x-rays, send us the periodontal charting, send us this, send us that. It's because we have no way of establishing medical necessity. Now on a ADA form, there is 4 spots for diagnosis codes, but nobody knows what to put in them because it's not something that we learn in school. Diagnosis codes are not something that we learn in academia. So there's that big gap there. And I'm not even sure if the dental carriers would know what to do if you did fill it out, because those 4 blanks have been there since 2012 and nobody knows what to do with them. But medical necessity is basically just you're providing a service to prevent, diagnose, treat an illness, injury, conditions, diseases. It's giving us a reason. Why do we do what we do? And there's codes for this. So things that we want to really key into is pain. There are diagnosis codes that point to pain, jaw pain, atypical facial pain, cancer. Has the patient had a history of radiation or chemotherapy? Is there some type of trauma? And what was the trauma to the face? Was it a fractured tooth? Was it a closed or open fracture to the tooth? Are they being impaired with their function? Obviously, if they're in pain, they're not able to function properly. If they have TMJ problems, they can't function properly. Sleep apnea, obviously that's a real dental, or not dental, medical condition. I was kind of surprised that they actually added codes to the CDT for sleep apnea. To me, this is purely medical. I'm not even sure why that was added to ADA. Anyway, bone atrophy, xerostomia, sinus defects, medical history of systemic conditions. So again, all of these terms, all of these conditions have diagnosis codes that go along with them as to a reason why are we doing the treatment that we're doing. In fact, there's over 72,000 diagnosis codes. Now, obviously, we're not using them all. There's other specialties that are using a lot of these codes, but there's a lot of them. And while that seems a little daunting, I find that there's a chunk that we use all the time. So a lot of what we do is repetitive, repetitive, repetitive. So establishing medical necessity using diagnosis codes. It's just that simple, but it's something that we don't know much about in dentistry, and we don't even document it in our notes. I often see, when we look at pain, I often see with pain, that not even always documented in the chart notes. I think we get so used to seeing pain that we just don't even document it. It's all the time. It's every day. So we need to document these things in medical terminology into our notes. But really, diagnosis codes are a golden ticket to everything. You will not get paid unless you put a diagnosis code with the procedure that you're asking to be paid for. In dentistry, again, you don't need to do that, and you get paid all day long for dental procedures by dental benefits. You don't need to establish medical necessity with diagnostic codes. So this is how simple it is. Severe atrophy. This is a great CT of maxillary severe atrophy. Horrible. This person actually has went through 3 different grafting procedures on the maxilla to try to improve the bone volume. And the K08.26 is severe atrophy of the maxilla. That would be the reason why we did the grafting. That simple. I think of this patient, it freaks me out a little bit to see how little bone she has, because I think of her and I think of, she's bouncing her grandchildren on her knee and she accidentally gets hit in the face. You're looking at a pathological fracture. I mean, it wouldn't take much to fracture that maxilla, right? Would it? Here's her mandible, same kind of condition. And that's what severe atrophy is. It's K08.23. So how do you look up these codes? It's really pretty simple. I use this ICD-10data.com. Now, I will tell you, the more that you use this website, the more pop-ups you get for the places you love to shop. So just know that. It took me a little while to get just this picture. I had to really do some fancy screenshotting so you didn't know where I shopped. But anyway, you actually just can put in severe atrophy of the maxilla or severe atrophy of the mandible, and it'll show those codes that I just showed you. But you need to use terminology that's used in medicine. So severe atrophy maxilla or mandible. It's not the lower or the upper. So we have to get using our medical terminology. How about this? Here's a great example of systemic condition. This poor gentleman, he was 21 at the age of this, at the time of this photo. And he had pancreatic cancer, had chemo, radiation. He also had several other conditions involving his pancreas. He had a pancreatic transplant. He finally got off of a feeding tube. He wasn't supposed to live past the age of 9. He got off a feeding tube and he had no teeth to eat with. So we were able to get all of his restorative dentistry taken care of, along with gingivectomies. He was not a good candidate for extractions and he was young. So that wouldn't have been the best choice. I know that he doesn't have much left there for teeth, but the dentist was able to do gingivectomies, get the crown lengthening, core buildups, and crowns placed. And we got that all covered by medical. Family was elated because they had medical expenses like nothing I've ever seen in my life, thankfully. But they didn't have the money to restore his teeth. So it was pretty cool. It was a great day for them. Great day for the patient too, because now he can chew. But again, you're not going to get a medical claim paid unless you have a medical or a diagnostic code. There's no such thing as truly as a medical or dental diagnostic coding. It's all medical diagnosis. So a claim will be denied if it doesn't have a diagnostic code on it that pairs with the procedure code. So where does it all start? It all starts really with evaluations. Here's a great picture. And I know as a dentist, as a hygienist, you're like, wow, those teeth are flapping in the breeze. And it's hard to look past the teeth, but you got to look past the teeth. There's a lot of things going on with the teeth that are, causing problems, but what else is there? Is there pneumatization of the sinus? Is there impacted teeth? Obviously, there's some severe atrophy in many places, disuse atrophy. And, we have to start somewhere. So look at all of our evaluations that we do. What I really dislike about dental benefits is, I look at the code 0120 and we have one fee that we get reimbursed for that. It doesn't matter if the patient is 10 years old or 100 years old. We get reimbursed what we get reimbursed, and that's all. Medicine plays at a different level. You're reimbursed on the complexity of the dental evaluation, whether it's straightforward, low, moderate, or high complexity, and the time that you spend with the patient, whether it is FaceTime or non-FaceTime. That's a game changer. So you are paid based on the complexity of that patient. Now, a 100-year-old patient versus a 10-year-old is going to have a lot more complexity, and you're going to be reimbursed as such. So I love that, because I am, it's disheartening for how much time that we spend with our patients, and how, we spend an hour with our patients in the hygiene room and we're not reimbursed well for that. I'm not sure how dentists actually make it the overhead that we have and all the tools and equipment that we have in a general dental practice, compared to a medical practice that has very little tools in it, or even x-ray units. They send you to an imaging center to have images done. So our overhead is high, yet we're not reimbursed for any of that. Hygiene, we look again at the diagnostic phase, the evaluations, PANS, fluoride, Velscope, oral ID, those adjunctive oral cancer screenings, looking at our frequency for PAN. We can either do a PAN or an FMX one time every 3 to 5 years on a patient. That's a total disservice to the patient. How are we, if we're always doing FMXs on a patient because they, 80% of our adult population has some form of perio and we need to monitor those bone levels, but we never take a PAN, we could be missing oral cancer. So we need to look at that frequency and what's best for the patient, not what the benefits are being taken advantage of from dental. Because unfortunately, it's that process of, we have a dental benefit with a lot of limitations, exclusions, and restrictions. That being, we can only do a PAN every 3 to 5 years, not what's medically necessary for the patient. Perio reevals, we now have an evaluation code that we can submit that doesn't involve the doctor even coming into the room. That could potentially be a great one for perio reeval. Salivary testing is another one. So all these things kind of start in hygiene, and that's typically where our patients come through unless they're in an emergency. We have so many tools in our toolbox, whether it's in the hygiene chair or the doctor's operatory, yet we're not reimbursed as an expert in the field. So I'd love to see that shift happen. One of the very first things that I incorporate into a dental practice is a new medical history that actually reviews all systems of the patient. So we're not just looking at the teeth, we're looking at everything. It also gets the patient in the game, and they're understanding that, wow, if I have a knee replacement, I mean I really need to tell my dentist that? How many times has that happened where somebody's come in, had a joint replacement or had a heart attack, and they don't think it has anything to do with dental procedures, but it does. So that's one of the first things I incorporate is a full-blown medical history. We take blood pressure. That's critical for us to know too, because we could have an event in our practice, a medical emergency, if we don't know if the patient's hypertensive. And it's a great way to screen for patients, and we need to document it. And part of that plays into our complexity of our patient and what we're reimbursed. Sleep apnea, we can absolutely make a difference with sleep apnea and screening for that. It's very simple to do, but it also helps identify and treat patients earlier on. It also helps with our complexity again. Here's the Epworth score, Epworth and stop bang, very easy thing to screen for sleep apnea in the dental chair. We also have patients that are diabetic, and we absolutely know that a diabetic patient has a lot of complications with periodontal disease. If we're doing surgical procedures, maybe the implant's going to fail because the patient can't heal. We need to know if they're diabetic. Super important. And there's great screening tools out there for that now, and understanding that whole piece. I love the Canberra model for the fact that they're looking at, we're going to assess, we're going to diagnose, and plan and treat. That's how medicine thinks. And I think, in academia, like you, Dr. Jackson, I know that that's how you guys think. For some reason, I know the reason why, when we get into general practice, it's easy to let some of these things slide because we run out of time. And we run out of time because we're not reimbursed, and we're trying to, we're trying to make a profit. And that's hard to do with some of the reimbursements that we are limited to with dental. So caries risk assessment is another thing that we can do, and fluoride is covered by medical carriers, but you need to have a diagnosis code to go along with the reason for the fluoride, and these are the diagnosis codes that we use. So as long as we have that paired with the fluoride varnish, we're going to be reimbursed by medical. So systems work, we need to have a plan. And part of that plan is, a head and neck evaluation. How are we screening our patients? Are we documenting it well? Are we documenting all that we did? Or do we have nothing to send to the medical carrier when they challenge us on what we do? We're doing more than just a oral cancer screening when we do a head and neck evaluation. And that warrants to be sent to a medical carrier over a dental carrier.
I have a quick question for you, if you don't mind.
Sure.
Okay, we have a little clinic in the equivalent of a little clinic in our dental school, which is wonderful. We can send patients over there for CBCs and blood glucose and stuff like that. Well, since COVID has been closed, I know that they will bill for those things when they do them in the little clinic. So I'm trying to say, why can't, if we're doing them in the clinic now that they're closed, why can't we bill for those glucose tests and CBCs and things like that?
You can.
Do we have to bill everybody? If we decide to bill for that, it's our choice. I mean, sometimes we do it because we think it's changed since the patient even got in the chair, because sometimes they do change. Maybe they ate a donut and it didn't start showing effect for a little while or whatever, you know. So it's mostly those diabetics. I do glucose screenings almost every day. I can't think of a day that I didn't have to do a glucose, because we don't do it.
That's fantastic.
But they don't charge for it.
Well, the problem that I see with the glucose and the A1C, there's machines to screen for this, but they're only FDA approved for if you already are diabetic.
They're already diabetic. They're documented.
I understand that, but you have to. There's some of these machines you have to have set up with every state's a little bit different as far as how you have to have it set up.
Okay.
But there are definitely ways that you can do that. I don't understand why we have a tool that we could use on every patient to screen for diabetes before we did a surgical procedure on them, to understand our risk factors and the potential complications. But the tools are only FDA approved for once you've already been diagnosed. To me, this is the backwards part of it. In dentistry, we prevent. We're very preventative oriented. In medicine, they treat the event. And that's a clear indicator of that, right? That's so backwards. Here we have a tool that can give us an A1C on anybody, but you can't use it on anybody. Well, you can, but you're using it off label of FDA. Makes no sense. It's crazy. It's crazy to me. It just doesn't make any sense. So you're right. PANs. Here are the two codes that we use for a PAN. If you wanted to do a PAN on somebody and they needed an FMX2 and you're going to try to tap into their dental benefits, you wouldn't be able to get paid for both. So these would be the two codes, the two diagnosis codes that we would pair with the PAN in order to say, hey, this is why we did the PAN. We're checking for maxillofacial and oral cancer, and they would pay us. Now I can say medical doesn't pay a lot on those, but it's better than getting zero for a payment. So this is what it can look like when we start to bill for things that we do every single day. You do thousands of these in a year if we look at a production report. So you have an exam on the first line, or an evaluation at $175. You have an orthopanogram that would be called a Panorex, but that's the real term in medicine is orthopanogram. You have a CT, and you have an interpretation of a CT in this situation. Now, the total charge was $1,050, and only 62 of that was not covered. Everything was allowed 100%. So look at an evaluation of $175 versus, and that was probably a level 4 eval out of 5 levels. You know, I mean, that's quite different than getting reimbursed $30 per evaluation. So it can look very, very different financially for a practice. Now, I'm going to put myself out there because my husband was just in the hospital with COVID. And I just recently got his bills, and it's astonishing to me what they charged. So this particular charge was for one of the specialty doctors, either pulmonary or infectious disease. I don't remember. They were actually both the same fee. But they charged out $495 for his evaluation. Our insurance paid $430.66. Isn't that astonishing? And here's his other one. This is from his ER evaluation. They charged out $1,619. Our insurance paid $1,133.30. Now, this was just for his evaluation in the ER. This was not anything else. Wow. So I was a little floored by that. Now, I get it. It's an ER, but we're like a mini ER every day with infected teeth coming in, you know, with abscessed teeth. But we definitely don't charge that. In fact, most dentists don't even charge the patient because they're going to be out of their frequency for how many evals that you do on the patient for the year. So often that's no charged. So you know, evaluations are a great opportunity for practices. How about, let's talk about imaging. How often do you see this in your practice? Like every day? I'm sure at the dental school you see this every day, multiple times a day. We know that 50% of heart attacks and strokes are due to an oral infection, whether it's periodontal disease or an abscessed tooth. Basically, an abscessed tooth is a cyst in the jawbone. That's where the infection lies, is in the jawbone. Yes, the tooth created it, but now the infection is in the jaw and it's running rampant through the patient's whole body. And our diagnosis code for this, the very first one, would be abnormal radiographic finding. Now, what that leads to is potentially a PAN or a CT to identify further how bad is this infection. In one encounter, you could be paid for your PA, for your PAN, and your CT, all in one day. So you're getting past the limitation mark. This is what's medically necessary, and it was done. This is what it can look like. In this particular situation, the doctor had just gotten a CT. She wasn't 100% comfortable with how to read it, so she sent it out for a read, and she billed it out, and she was paid 100% of what she charged, which was $648 or $46. The diagnosis codes were abnormal radiographic finding, and these diagnosis codes came from the radiologist who read it. The M85.88, which is bone density structure, specified disorder of bone density, cyst of the jaw, which was the abscess, and chronic disease of the tonsils and adenoids. That's what the radiologist gave. So we used those diagnosis codes, sent it in, and were reimbursed for that. Now, what also is alarming to me is that often practices buy this beautiful CT machine and they love it. They've diagnosed more than they've ever been able to, but what they run up against is dental not covering it. And even if it did, if you charged $250 for it, you're tapping into the patient's benefits. And what if they only have $1,000 benefit? So you're tapping in and in and in, and now they have nothing left to restore their teeth with. So this gives you another opportunity to submit it to medical. But I often see these no charged. They just don't know, the practice doesn't know how to bill it to medical, so they just get frustrated and they just go, we're not going to deal with it. We aren't going to charge for it. And now you have this $100,000 machine not getting you any return on investment, which is sad for me to see, because in a medical office, you would never get a bill that would say no charge. It's not going to happen. So, and they're going to charge you a lot more than what we do. So CTs are absolutely billable to medical. Here's an example of a retro bill that I did in a practice. And that's the thing. Most medical carriers, you can do retro billing. So up to a year for some carriers. Some are maybe only 90 days. Some are 180 days. So you just don't know. But a lot of carriers are 365 days that you can submit a claim. In this situation, we submitted a claim for an abscessed tooth. We submitted for the evaluation, the PAN, the tomographic study or CT, the cyst removal, and notice what they paid on that. That encounter looks a little different than what most offices charge. Most offices wouldn't charge, they would charge for the extraction that was probably done on this patient, and none of this. So look at the opportunities. They're there. And we're saving people's lives. We're saving them from having a heart attack or stroke. We're saving them from having uncontrolled diabetes because they got an infection in their mouth. So, you know, we have to look at the big picture of the impact that we are helping patients. So again, looking beyond the teeth, this is what some medical diagnoses could look like for this patient. And, you know, there's very little there about the teeth. It's all more the structures around the teeth that we're using. I do want to bring up deductible because it's an important topic. Not every code goes towards deductible. It's going to be based on the patient's quality of their policy for the most part, whether or not that particular procedure code applies to deductible at all. So we need, I hear this all the time, well, patients have such high deductible. They do, but it doesn't mean that the procedure code is going to go even towards the deductible. We won't know that until the claim gets processed through. But you can be safe to say that the deductible needs to be met first. I'd rather have you say that than, you know, have false expectations to the patient. Here's a great example of this. We have a patient that had all the diagnostics done for sleep apnea. So a tomographic study, CT, an orthopanogram, eval, the pharyngometer, and lateral ceph and rhinometry, and nothing went towards deductible. Everything went, there was a little bit that went towards co-insurance, but nothing went actually to deductible. Now, same data service, the HST was billed out. There, that one went to deductible. So again, it's based on the code. It's based on the policy and the quality of the policy and the code. What's important to remember in all this is that we can't, even if we're billing to medical, we can't assume that medical is going to pay anything. We're doing it as a courtesy to the patient to try to eliminate some of their out-of-pocket costs. We need to have good financial arrangements in place. And there's ways to do that with Care Credit, you know, there's Lending Club, there's all sorts of different options. There's different banks. There's even with my services, I'm able to get, you know, Huntington Bank to help cover my services to help implement and teach offices how to do this. So financial policies, if something goes towards deductible, copay, co-insurance, that is patient's responsibility, and we need to collect that from the patient. We can't not do that, and we can't let our AR get out of control. So financial arrangements are super important. A couple other things that we need to shift our brain around is documentation and terminology. When I went to hygiene school, we learned SOAP notes. We learned in SOAP notes back in '93. I see very few practices that use a SOAP note. I see even less using an operative note. Again, these things go by the wayside once we get into practice because of our time constraints, but we need to. I mean, if you ever get audited and you're not meeting medical necessity, you're going to pay back a lot of money. And that's going to happen whether you're not showing medical necessity in your dental notes or your medical notes. Your note in general has to meet medical necessity. That's what they're going to be looking for. We also need to get past our phony baloney language that we like to use. Implants, we call that a bone fixture in medicine. Panorex is an orthopanogram. So bone loss, it's bone atrophy, disuse atrophy. Abscess is really a cyst in the jaw, it's an infection. So we need to use better terminology in our notes. It's great to use some of this terminology with our patients when we're sitting eye to eye with them and talking with them, but when it comes to our notes, we want to beef it up a little bit. I would love to see more dentists getting paid as a specialist. I have here just an example of what medical versus dental can cover. However, the dental side, not always do they cover any of these. And quite honestly, if they did, they're not going to pay you $8,000 because you will have well met the patient's 5-year limit on benefits. So we don't have that in medicine. We don't have that cap where they say we're not going to pay you anymore. We have to abide by certain things like deductibles, copays, co-insurance, but we're not going to get capped out at $1,000, $2,000. So there is no comparison between medical and dental reimbursement. The only things that I see reimbursed lower typically on the medical side is a PAN. Anything else is going to be far above anything that you get paid on the dental side. I show this because I don't want you to be afraid of even thinking about going in network with medical if you're able to. It does make it easier. You don't have to be in network though. But if you're not in network, it does limit you the policies that you can tap into for reimbursement. Like you can't tap into an HMO or an EPO. Those closed networks, those have to be billed by a provider within those networks. So you're looking more at PPO insurances. So the ROI is absolutely there. There's no doubt in my mind. I have this as well. This is from a carrier, and I have a fee schedule for medical against average for dental. It looks very different. And again, look at the very bottom, the evaluations, $32 to $50 versus all the way up to $170. And this is actually, it's at least a year old. So those fees, the reimbursement has changed a little bit, but it's very, very different on the medical side. And yes, you can tap into both to get as close to your full fee as possible, which is great if you are a PPO practice. If you can bill to both medical and dental, because being in PPO, you're probably already writing off 30 to 50% write-off by being in network with those dental carriers. So now you're able to tap into it on the medical side. If you look at just doing the math, just think about how many exams you do in a year's time, $30 versus $75. Would that impact your business? What about CTs? What about if you're not charging CTs at all? And I could tell you that an in-network provider is getting $150 per CT taken. That's an impact. Cyst removals, so those abscess teeth, anywhere between $500 and $1,000 I see reimbursed for that. I've gotten paid $9,500 per quadrant of grafting before. So it's a whole different ballgame. The things here on this screen, doing the math, those are just easy peasy things to get reimbursement for. Surgeries are a whole different ballgame. Sleep apnea is a whole different ballgame, but there's so many things that we can build to medical. I want you to look at the marketing opportunities. I know how hard dental practices work on getting new patients into their practice. We work really hard for new patients. What if you could say, you know what, we can actually see patients for an evaluation that have medical benefits. People that don't have dental benefits typically don't come to you because they don't know how they're going to pay for your services. So there's a whole chunk of patients out there that don't have dental benefits but have medical that you could see. That opens up a whole opportunity. Marketing to hospitals. Most hospitals do not have a dentist on staff. So what do? They send the patient to a dentist. The patient doesn't go because they don't know how they're going to pay for you. They didn't come to you in the first place because they knew they had a toothache, but they didn't have dental benefits to tap into. So they ended up at the ER. The ER tells them to go see you. They don't go. They come back to the ER, and some of those patients end up having a heart attack or stroke, or they die. And I know that's a reality. I have a friend that's a transplant nurse, and she's like, you have no idea how often that happens. Something so preventable. It's heartbreaking to me. We can increase our case acceptance because we have another way for the patient to help eliminate some of their out-of-pocket costs. Consider going in network. It's a great marketing opportunity, just like it is on the dental side, to have your name associated with the medical carrier. So here's an opportunity as well. This is from a patient that I helped her get her benefits for when I first started with this. And I said, hey, Jane, will you write me a testimonial? Because I think it's really important to get a patient's feedback on this. How did it help them? Because I would bet less than 5% of dental practices are billing to medical successfully. This is a game changer. And when a patient can write you a glowing review like that, is that going to help your practice? Is it going to build your practice up or tear it down? It's going to build it up. So great opportunity for many marketing avenues if you tap into that. So it's about it's about closing this gap between medical and dental, collaborating with one another to try to help elevate our practices, elevate our patient care, and get patients the treatment that they so want and they deserve. You know, if you're ready to take that big jump, that big leap, feel free to reach out to me. I'd love to talk to you more about it. And like I said, it's an exciting time in dentistry. And I can't wait to see one day when I retire, the impact that I made on our practices and our patients. What questions have you guys got?
Thank you so much. This was really fruitful information. Like I never really understood how deeply you can actually start to look into the medical billing component. So this is very eye-opening.
You probably won't think of tomorrow when you go into well, you're not going to be in the clinic tomorrow, but you know, when you go in the clinic next week, you're going to think differently about what you're seeing and what's possible, because I know that you see patients that can't afford the treatment.
Yeah, and I was just thinking about Dr. Babbage. She is like in the little emergency room every day down in there in our emergency clinic. Like there's so much that could be differently there too.
Yeah.
Exactly. Hi, this is Tiffany McFeeters. Am I going to pronounce it right? Kendra?
Yep, you got it.
Kendra. I think I came in kind of like 10 minutes in and I may have missed the first part. I had no idea, like Dr. Jackson was saying, that you can build to medical. So I guess it's just a matter of, so I guess I want to know exactly how do you do, like you have to know, so do you have to combine a dental diagnosis code with a medical billing code to an insurance company, or exactly how do you do that?
Well, they're all medical diagnosis codes. Yes, you would put on the medical claim form diagnosis codes that pair with the appropriate procedure code. So that's the learning curve, because that's not something that we're taught in school. And that's what I help practices with, is identifying, you know, how to identify those diagnosis codes. You know them in your head, but you don't know what the codes are. So that's how you get a medical claim paid. And in dentistry, and I don't know if you were on when I talked about this, but in dentistry, we never have to use a diagnosis code to state why did we do this dental procedure. You just bill the dental procedure all day long and you get paid. Medicine doesn't work that way. You have to have a diagnostic code to go along with the procedure in order to be paid. It has to make sense. It has to make sense. Why did we do this procedure? Like with bone grafting, to have moderate or severe atrophy or paired with a graft, that would make sense to them. We did the graft because there was atrophy.
Okay, so would you say this would be most beneficial for surgeries, like for oral surgery, when you have to do bone grafting and extractions and like you were saying, cyst removal? So the medical portion would be more beneficial there. Like, how does this play? Can you use this in terms of pediatrics or PROS?
Yes. I'm gonna go back to this, one of my very first slides, so that you can see that of all the things that we can bill. Oh, there we go. So here's all the different things that we can bill to medical. So for pediatrics, you're looking at a lot of frenectomies, fluoride varnish, advanced oral cancer screenings can be billed. Your evaluations can even be billed.
Thank you.
Yeah. So there's a lot that can be billed. It's just a matter of what you want to tap into for your practice. And I usually start with easy things in a practice to get people's heads wrapped around this whole process, because that's where I saw the failure. Is it's just a different mindset. It's just a different system that we have to now incorporate from dental. So that's where my company lies, as far as the implementation of this process, so that you can get to a point where this lives for the life of your practice.
And do you usually see a big change in the offices as far as finances and revenue? Do they actually bring in, do you see like a significant difference
Yes.
in the amount you do? Okay.
But again, it's gonna depend on what you bill. It's gonna depend on, do you bill all you can? Do you, keep your lower dental fees, or do you try to match medical more? So, because I often see exams go to medical, but if we're keeping the fee that we are kind of limit ourselves with dental, well, we're leaving, I see exams paid at 100% on the medical side. Well, it just means that our fee was too low. So, be willing to be coached as far as that too, and take advantage of, well, not really take advantage, but tap into what's going to be offered to you from the medical side.
I see. Thank you.
Mm-hmm.
This was very good.
This is Linda Larkin.
Yeah.
Do the patients have an issue with you using their medical insurance? Do they question that instead of?
They really don't. Sometimes patients don't want to give you that information. I think they're more afraid of, especially like with sleep apnea, they're afraid of that going on their record, because if somebody is diagnosed with sleep apnea and say they're a truck driver or a pilot, that they maybe don't want their medical insurance being tapped into for sleep apnea. But most patients are very thankful that they have less out of pocket to pay.
Okay, thank you.